All right. Well, good morning, everyone. This is my first meeting as chair, so I'm going to call the meeting to order and take roll, and hopefully you guys will jump in as I completely mess up the way I'm supposed to be doing this, but I can just
I'm on it.
go down the list as I see it here. Harry Skoletsky.
So Harry's not part of quorum. Harry
Okay,
is
just the
our
quorum.
legal counsel that is sitting in for Reza
Got
as
it.
Reza is enjoying his time as a new father.
Oh,
So you would roll call attendance, which you could start with you and count yourself, and then go to Ruth, and then Kenneth and Lilith, and then at that point we'll have four, which is the minimum required for quorum.
Great. Hang on one second. I'm actually having trouble hearing you.
I will grab headphones and make sure that I assist as well.
Okay, awesome. Kenneth James
I'm here. Good morning, everyone.
and Lilith. Are you there? Oh yeah. Hi.
here.
And Ruth.
Good morning, I'm here.
Hi. And I am also here. So we have a quorum. Let's see.
This one here, we'll turn it over to board moderator for general instructions for the format of a teleconference meeting, please. Thank you, Mark.
Good morning. This is the BRN moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature. When the committee reaches a point in the agenda at which public comment is appropriate, the question and answer feature will be turned on, and members of the public can indicate that they would like to make a comment by inserting the phrase, "I would like to make a comment," in the question box, which is typically in the lower right of your screen. We will also query our physical location here in BRN HQ. That is represented by BRN Sacramento on your screen. I will then call on the individual and unmute their microphone. The individual will have 2 minutes to make their comments. I will not give a warning as your time approaches. I will mute your microphone and will announce that your time has exceeded the time allotted. I will then proceed to the next member of the public who has a comment. Please note that the question and answer feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. When your turn comes, you will be prompted to unmute. If your question can be answered, the committee will respond accordingly. When making your comment, speak about anything you believe is important for the members to know. Remember, committee members cannot address any item not on the agenda. Items not on the agenda at that moment, items that you would like to add to a future meeting, or items that will be discussed later on the agenda will be discussed at the correct times during the meeting. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when committee members or BRN staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will mute your microphone automatically. Thank you.
I'd like to do a little mic check really quick. Jen, are you able to hear me better now?
Yes, thank you.
Wonderful. Okay, I've got headphones on, so we're set. So now we will move to 3.0, which is where we give the public the ability to make a public comment. And so we'll have you move on to that one, Jenna.
Are there members of the public who wish to make a comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Holly Smith would like to make a comment. 1 second, please. So Holly, on your screen, possibly behind a window that you have up there, you go. Thank you.
I hope I'm jumping in at the right time. I literally came from another call and I realized we're on public comment. So I'm just going to shoot a public comment. I don't know how germane it is to the current conversation, but I just want to ensure that I see it on the agenda for today. But if we don't get all the way through it, to ensure that upcoming agendas include our SB 667 regulations or any regulations that are to be promulgated based on that bill that was signed a year ago. There are some things in there that relate to furnishing and scope, minor things, but nonetheless, just mostly want some discussion and understanding about when there will be some more information on that. So that is all. Thanks, everybody.
Yeah, no problem. And just for everybody to know, because that is an agenda item, typically we would not hear public comment on, but I didn't want to interrupt at items for not on the agenda. So if you're able to come back on when we get to that agenda item, we'd love to have as much input if you'd like to deliver at that point. Thank you.
Thank you for your comment. Committee Chair Shah Batista, there are no public comments requested on the WebEx. We have no physical participants yet in HQ. Would you like me to close this window?
Yes, thanks. It looks like we can move on to the next agenda item, which is to review and approve last meeting's minutes. Did everyone have a chance to take a look at those?
Yes.
Any comments? Anyone move to approve?
Motion to approve. The lid.
Can I second?
You can second, or you can motion to approve if Lilith didn't do it. So you are not excluded from
All
doing any
right.
of that.
And I think we have approved the March 26th meetings. Moving on to agenda item 5.0, discussion and possible action regarding meeting dates for 2025. I think we were gonna try to keep them in alignment with the NP meetings. So I don't know if those dates were selected.
Immediately to follow this meeting, they will be voting on those as well.
Okay.
So the dates that we have asked for you guys to consider are in the agenda package here, starting at page 16. And it is March 18th as well as September 25th. So we would like you guys to take a look at your calendars, make sure that you don't have any vacations, holidays, birthdays, surgical procedures, etc., that are scheduled around those dates that you would not be able to attend. As you can tell today, we have the minimum quorum. So if one of you guys were not able to make it, we would actually not be able to hold this meeting today. So if you can take a look at that and make sure those align, and if they do, you could make a motion to accept these dates for next year. And if you are unable to accept these dates for next year, we would like you to propose a different date, and then we would share that with the NPAC members later today.
Well, it looks like these are the same dates that we had kind of tentatively blocked off in a prior meeting, and so I would move to approve them if they work for everybody else.
It worked for me.
Yes. They work for me also.
Okay, so we have a motion to approve by Jenna. Do we have a second?
I second.
And that was Ruth, correct?
Ruth?
Yes,
Yeah.
yes, this is Ruth. Yep.
Wonderful. Thank you, guys. So if you go to public comment, Jenna?
Sorry, there's a public comment on the minutes.
For every agenda item, you have to take us out to public comment. So this agenda item, we have a first and a second. We now need to go out to public comment.
Are there any public comments on the minutes?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." And this is for agenda items, the 2 agenda items, correct? Just because we missed it on the last one?
Sure.
Did we not go out to for the meeting minutes?
No.
We didn't. Yeah. So we'll hear public comment for agenda item 5.0, meeting meeting dates, and agenda item 4.0, which was our meeting minutes.
Perfect.
Are there any public comments?
And
Hold
committee
it
should,
open for
yeah.
30 seconds to allow for anybody to come in and type that they want to have a comment. So you'll hear a period of silence.
Right. Sorry. So Committee Chair Shaw Bautista, there are no public requests for comments on the WebEx. We have no physical representation here in HQ. Would you like me to close this window?
Thank you. Yes.
Thank you.
And then you'll just do a roll call vote to pass the motion.
Let's take a vote. Are there any dissenters? Everyone
So
else approve? Say aye.
So we actually can't do that. We
Oh,
actually
you
have to do a roll call
Okay.
vote. Yep, you have to
Ruth,
do
how
a
do you
roll call
vote?
vote for each one. Sorry about that.
No, that's okay.
I am in favor of those dates.
Great. And Kenneth
Approve.
and Lilith.
Hi, I'm in favor.
Great. I approve the dates as well. We can
The
move forward.
motion passes and we can move on to item 6.0. And then board moderator, can we elevate Shannon so she is available for discussion when we speak about item 6.0, please?
So 6.0, this was a requested regular report out on disciplinary cases and their disposition. And as we have discussed previously, it looks like the numbers are very low. I really appreciate seeing it spelled out in this way.
An item of clarification really quick. I had a comment from staff that wanted to ensure that the vote that you guys just took to pass was also passing the meeting minutes, since we did not do a roll call vote on the meeting minutes. If not, we can do another vote to substantiate that the meeting minutes pass as well.
I was voting for both.
Kenneth, Lilith, were you guys voting for both as well, or just a singular vote on the dates?
I approve both.
I too approve both.
Ruth, did you approve both?
Yes, sorry. Yes.
Thank you. No problem. So we just have that noted that that was done, and we will do better moving forward. So item 6.0 is up on the agenda, and did you want me to open it up and kind of do some history on that, allow Shannon to give some ideas, or Jenna, did you want to take this as it was requested by you and open it up, or do you want to just?
I think it would be really helpful to hear a little bit more about how these data were collected, and I think it was Macaulay who had pulled it for us, so whoever would be best to speak to it.
Macaulay just asked for it to be pulled, but these numbers come from our enforcement area, and Shannon Johnson is our chief of enforcement. And so Shannon, if you are able to kind of speak on the data that's on the agenda item 6.0, we would love to hear from you.
So good morning, everybody. Shannon Johnson, I'm the Enforcement Division Chief. We have a staff that pulls all of our reports for us, and what she pulled was all disciplinary actions going back. I can't remember how many years back we went, but we can go as far back as the inception of Breeze. Excuse me. And so she pulled all the disciplinary action and then connected it with all the RNs that have an advanced practice certificate. And so that's how she came to the numbers of not only NMAC, but she did NPAC as well. And we do have the numbers on all the other advanced practice certs. So I know at one time we did report to the board all of those numbers broken out. And we may start doing that again, but I know we have at this meeting. I believe last year we also presented these numbers. So what you're getting today is just the updated numbers from that report.
Can you clarify for me, this is Ruth, what 801 practice is?
An 801, that's the insurance claim. So anything by law, anything over $10,000 for insurance settlement must be reported to the board. So those settlements, those are the cases that you're seeing under the 801. We receive those and then we run our own investigation if needed and kind of run the same gamut as we would any other complaint.
Okay, thank you. And then the type of discipline chart and the violation, the totals on those are exactly the same. Does that suggest that these correspond? These are the same people or not necessarily?
I'm sorry, which are you asking about?
Well, both charts, the type of discipline and the violation type, you know, the totals, running totals on the bottom are exactly the same for the different years. And does that mean it's the same person or same
No.
persons? Not necessarily.
No,
Okay.
no. We make sure that there's no duplicative information on there. So when you're looking at now keep in mind too, if you have a complaint that comes in 2018, the actual disciplinary action may not be concluded until 2020.
Got it.
Each year represents the actual disciplinary action that has been concluded. So whatever that disposition is in that year is where it's reported. So that each year stands on its own, and those are individual disciplinary actions for each of those.
Okay.
And it does show, you know, like on 2018, it shows that there was 5 people that did have or 5 types of discipline. And then below, it does show that there were 5 types of violation. So there was 2 in practice, 1 in 801 practice, 1 in conviction, and 1 in other. And so it would be safe to assume that the discipline above on the first document came from the violations listed below. But it is not a direct like one-to-one that says like, oh, the 2 practice violations equaled on the top line the 1 public approval. Those don't match up, but the numbers do. So hopefully that.
And the other thing I want to point out too, for instance, just take 2018, that voluntary surrender during probation. It's probable that it's not one of those 2 probation cases. One of the conditions of probation is that they're allowed to surrender their license at any time voluntarily. And so more than likely, it's probably from a previous year disciplinary disposition for probation.
Got it. Can you give some examples of what would fall into the other violation types, since there seem to be some from year to year, most years?
You know, I can't recall off the top of my head the other. I could pull that. I just don't have it right offhand. Can we put up the other slide on the
Violations?
Here we go.
I'd have to pull up that data. I can't recall what the other was, but it just obviously doesn't fall within practice or conviction. Sorry for that, but I don't recall what that is, and I don't want to misspeak on that.
Sure. I mean, these are really small numbers, so I guess it would probably not make a whole lot of sense to ask about trends, but I am curious if you can make any kind of comparison to other licensee types, or if there's differences or similarities between the discipline cases you see among midwives and other licensees.
Well, if you're talking about other certificate types, so when
Yes.
you're looking at, I mean, really based on population. So if you look at the midwifery population, it's very small.
Mhm.
So obviously in comparison, but with you know, the APRN type, or excuse me, the population compared to how many disciplines we have, it's very comparable to every other advanced practice cert. And as you can see also with just RNs without the APRN, you know, based on our population of over 500,000, it runs right along the line with RN disciplinary actions, which is, you know, less than 1% of our population.
And for the same types of violations, or are there those similarities hold true as well?
Yeah, with RNs, and what we've seen over the years, though, is previously our conviction cases, excuse me, were a little higher than our practice cases, and it seems to have flipped over maybe the last 7-8 years. It's trending in the opposite direction. That practice cases are now a little bit more than conviction. So, you know, that's maybe why you're seeing it here too. Practice cases, you know, are two, you know, if you look, or actually in the last few years, you haven't had any practice cases and only one conviction so far, like for 2024. 2023, you just had the two other, and again, I apologize, and I could look that up. But 2022, you had two practice, no convictions. So it's kind of running along the same trend as just an RN without an APRN and the other APRNs.
I think the
And
one
just to
difference
be
would
clear,
be the 801 practice. Is that correct?
I'm sorry, I didn't hear that, Lori.
I was thinking the one difference would be the 801 practice. Is that correct?
I still didn't hear you.
So the 801 practice, because it's an insurance claim, would be more on the certificate holders and less on the traditional RN. Is that accurate?
Yes. Yes.
So it sounds like, and please correct me because I'm just making guesses here, practice is clinical issue. 801 practice is a clinical issue that rose to the level of beyond a $10,000 settlement. What's OSD?
State discipline.
Other state discipline. Okay. And then illegal conviction, substance use disorder, sexual misconduct, and then this catch-all. Huh. Any comments, questions? Surprise, not surprise? Hey, well, let's see. I guess we can put this out to public comment. Oh,
Correct. So I was just going to make a motion here that make you guys aware that because this is information only, there is no motion that is needed. So we will not need a first or a second. But at this point, yes, Jenna, you can take it out to public comment.
okay. Are there any members of the public who would like to make a comment?
We will be opening
Our
for
board
public
might-
comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Holly Smith would like to make a comment. 1 second, please.
There. Yes, I just have a question. The screen is different now, so I'm going from memory, but the practice row there and the 801 practice. The 801 practice is not necessarily part of the practice, correct? Like it could be that they are separate things, meaning that 801 practice, those indicators there may or may not be one of the practice issues that came up on the line above it. Is that right? if folks understand what I'm saying. I'm trying to piece together that they are not necessarily connected. Is that right? And then the second comment is convictions. Are those practice-related convictions or really any criminal conviction?
There any criminal conviction.
okay.
And then Shannon, correct me if I'm wrong, but the 801 practice and the practice can be two separate things, or
They are
they
two
can
separate
be.
things. We
Yeah.
count them as either a practice or an 801 practice. We separate them out. I mean, if we wanted to do just practice in general, we would just combine the two numbers. We just wanted to kind of break that out so you could see which were actually insurance settlement cases versus just a practice issue.
Okay. So then another way to say it is that one there in 2018 for 801 practice is one of the practice violations in the top row there in 2018, or no?
Is not
It's not. Okay, very good.
one
Okay,
of the
thank you.
two practice violations in 2018.
Okay, very good. Thank you.
Thank you for
That's
your
all.
comment. Thank you for your comment. NP still watching would like to make a comment. 1 second, please.
You. Yes, when the screen changes, it's difficult to refer to the data. But the data I wanted to refer to actually is in the material minutes for the NP meeting that is after this. I think it's difficult for the midwives to actually see like the big picture, because the data in your packet is just referring to midwives. And I think that the important thing, advanced practice practice-wise, is looking at all of the advanced practice nurses. The important thing I think to capture is from 2018 to 2024 as of August 31st, and this data is in the packet for the meeting next. There have been a total of 382 advanced practice nurses disciplined from 2018 to 2024, and one advanced practice nurses, including midwives, has been reinstated. So if you just happen to be an advanced practice nurse and you're disciplined, one of us has been reinstated. And any of us could be disciplined. Anybody can make a mistake. And so that's 0.002. So that's less than 0%, or a little more than 0%. And your conviction could be something that happened in 2017 and you weren't even convicted of a DUI. You were convicted of something else, and that's still related to nursing. So I just want to say, this is not the big picture. These numbers are low, but any of us could be disciplined. And so please, look at the big picture. Thank you.
Thank you. So we'll take that second to provide some clarification. A public reproval, you still have your license, so there's no need for a reinstatement. You're continuing to work. The probation, you still have your license. There is no need for a reinstatement, so you're still able to work. So all of your public reprovals and your probations, those do not require a reinstatement, since your license remains active and you are able to remain in practice. Your surrender, your voluntary surrenders, and your revocations, those are the only 3 lines that cover where a license is no longer able to be utilized, which would potentially require a reinstatement if they were to return to practice. The reason why we did not have the nurse practitioner data on here is that is mandated in law to go to the Nurse Practitioner Advisory Committee, just like you guys are mandated in law to have this data go to the Nurse Midwife Advisory Committee. Additionally, just another point of clarification is this data, today's data, whether it's on the certified nurse midwife disciplinary status statistics or the nurse practitioner's disciplinary statistics, is not inclusive of all advanced practice RNs. We do have 2 other advanced practice groups, and that is our certified registered nurse anesthetist, as well as our clinical nurse specialist. And they do not have a meeting today, so they will not have data up and pulled. The other thing to just let you guys all know the process and be aware of that is when we have conversations that is inclusive of all 4 advanced practice RNs, there are 2 locations that you would find those, and that would be in the board's nurse practice committee, where they look at all 4 certificate types as well as the RN, and to the full board. So there are areas where you will see this data come together. And as Shannon had mentioned in her presentation today, she said that we used to have this data reported out to the board and breaking it down. And that is directly related to where this would be reported out. And that is typically done on request of our board members. So just so that you have a complete understanding. And then you can't necessarily compare straight numbers from one to the other. You have to go on a percentage base. That's the key. As Shannon had mentioned, we have well over 500,000 RNs. And so you will see a large number of discipline when we look at RNs, but it is a very small percentage. When midwives, we have 1,400 nurse midwives in our state, but we have almost 41,000 nurse practitioners in our state. Therefore, when you look at the numbers that would be skewed, you would have to look at the percentage, which is where Shannon had mentioned in her report out that it is less than 1%. And that goes the same when you're looking at the clinical nurse specialists, where they have 3,000 as their base number, and the certified registered nurse anesthetist has 3,000 as their base number too. So you cannot compare direct numbers. You do have to go down when you're comparing each group by looking at the percentages. So just some helpful data out there to make
Lori,
those tables a little more clear. Yes, Shannon.
I just also want to clarify on the reinstatements, because not everyone's clear on that. Reinstatements are not just us giving the license back. The RN needs to petition for the license back. So they have to petition the board once they've surrendered or their license has been revoked. On a surrender, it's at least 1 year, possibly 2. On a revocation, it's 3 years to petition for reinstatement. And I'll just say across the board, very, very low percentage of our disciplined RNs ever petition for their license back. So if that number is low on petitions, it's simply really because they have not petitioned to get their license back.
So that clarification, Shannon, is that we're not denying necessarily those reinstatements as the BRN, but that the person that received the revocation or voluntary decided to surrender chose not to ask for their license back. Is that accurate?
Correct. Yes.
Hey.
Board moderator, is there any additional public comment on the web or in person?
All right, there are no other public requests for comments on the WebEx, and we have no physical representation yet in HQ. Committee Chair Shaw Batista, would you like me to close this window?
Yes, thanks. Looks like we can move on to agenda item 7.0, discussing the composition of the subcommittees. We currently have public engagement and website, scope of practice, regulations, and education. Let me pull up the meeting minutes. It looks like our current subcommittee members are not listed in the materials.
This is a report out, and this is where the subcommittee members of public engagement and website, if they are on, would take this opportunity to provide any updates that they've done between the last NMAC meeting and this NMAC meeting. And so At that point, we do have the public engagement and website is vacant. So we do not have a person assigned to that one. And so then we could pull up the nurse midwifery scope of practice. And that would be Jenna and Ruth. Do you guys have a report out of any work or information that you would like to share with your committee members today on work that was done between the last NMAC meeting and today on the nurse midwife scope of practice?
Not that I am aware of, unless Ruth had received any communications separately, but we really have not received inquiries that I'm aware of, nor tackled any new topics.
Have you guys had the ability to meet, or is that something that is planned for the near future?
We didn't meet. I think that we maybe had a little bit of a misunderstanding. We were thinking that well, maybe I don't want to speak for Ruth, but my thinking was that we didn't have much of an agenda outlined for ourselves other than being responsive to inquiries and assisting with further clarification as needed. So I'm not sure. It looks like Ruth might have stepped away.
If she did step away, we will have to wait for her to return before we can make any motion or anything on this meeting, because we will need to have quorum. And without her here, we do not have quorum. We can continue with information only. There would just not be a further motion. So then we can move on to Dr. Byrne and Lilith. Did you have anything to report out on regulations? Have you guys been able to meet? Did you get any inquiries, anything that you guys have worked on between last meeting and this meeting that you would like to share out with today's Nurse Midwife Advisory Committee?
We have not met and don't have new information to share.
Okay, and so then we would go down to the Nurse Midwifery Education Subcommittee, which is Rebecca and Kenneth. We know that Rebecca is not on, but Kenneth, are you able to share any updates of any work or meetings that you guys have had from the last Nurse Midwife Advisory Committee and today's Advisory Committee?
As everyone else, we did not, and that is my fault, and I'll be more attentive for the next meeting. So no updates.
No problem. And if you guys need to do like a kickoff meeting or meet with us outside of this, we can, Macaulay typically does a reach out. I'm pretty sure she sent out some emails offering up, but I could make sure that that is done again, where you can come on, you meet with myself, Macaulay, legal counsel is typically there, and we do a kind of a kickoff meeting with you guys, just kind of talk about different items, different maybe focus that you might consider, answer any questions that you guys may have, and then really try to help to facilitate you guys working on your own in between these noticed meetings, especially with the next agenda item, where they're asking for work on potentially regulations based on a bill that was passed. And so at that point, if it is a scope of practice issue that you guys would want to kind of get some guidance on, that may live with Jenna and Ruth's subcommittee, they might go through 667 and say, is there anything that affects scope of practice that we might need to update and look at? And then if there is something that needs to be kind of highlighted and updated on this next agenda item, and it does not require regulations, but really just getting the message out, that would go to the public engagement and website committee member, which is in active recruitment, and we should have that approved at our next board meeting. And so then we could do some messaging out based on their feedback, or as we expect in the next agenda item, there will say that there will need some regulations that will need to be written to carry out 667. And if there are regulations that would need to be done, we would put that out to both Dr. Byrne and Lilith, and you guys would look at that and work with us and our legal counsel as well as our chief of legislation and DCA's reg attorney. And we would together draft some regulatory language that we would then bring back into the larger advisory committee so that you guys can vote on those, accept those, and then move them forward. But the work begins in those subcommittees. And so hopefully that is where we can provide some assistance with that. If when looking at 667, which I know it doesn't, but just hypothetical, if it addressed nurse midwife education, then we would kick that section over to Rebecca and Dr. James, and we would be able to take a look at that and see if there's anything that needed to be addressed around education that we would have to look at. So that is where your roles in these subcommittees fit. And that is why we made those subcommittees. So a lot of that work can be done in between these committee meetings, because when we come onto these committee meetings, they're 2 to 3 hours long. You can't do a lot of in the trenches kind of work on wordsmithing and getting legal counsel opinion and going out to subject matter experts and really kind of engaging the community the way that you guys can in these subcommittees. And then this is the modality where you guys would report out all the work. If you got to a point where you had a final project, we would actually not agenda-ize it like this. This is a standing agenda item. And so what we would do is while you guys are working on, say we're working on regs with Dr. Byrne and Lilith, if you guys had questions as you guys went along, if you just wanted to say, hey, you know, we've met a couple times, we've met with subject matter experts, these are kind of the path that we're looking at, this is where you would report that out. If you had language that you guys had finalized and wanted to get impact and assessment and input, then we would make a separate agenda item like 8.0 that would say more in depth on the regulations and what they were, what the language was. And then at that point, you guys would have a very robust discussion and hopefully make a motion to accept the regulatory language as written or with edits. And that motion would be to present it to our board. And then we would then carry that over. When it was in front of our board, we would ask for Dr. Byrne and Lilith to accompany us to the board meeting in a virtual manner so that you guys could give any direction or feedback or thought process behind it if you chose to. If you're not able to do that, we are able to meet with you ahead of time and we can present at that point as well in your place. And so that's just kind of just a basic overview of these subcommittees and expectations between the noticed meetings on how you guys would move things forward and be able to present out to the full committee. So at that point, it looks like there has been no meetings of the subcommittees in between the meetings, and so there's nothing to report. We will go ahead and reach out and try to engage with you guys again to try to get some meetings going and help facilitate this. And so at this point, it is information only. And so I asked Jenna that you take us out to public comment.
Are there any public members who would like to make a comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, I would like to make a comment. Please remember you will have 2 minutes to make your comment. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Committee Chair Shaw Batista, there are no public comments on the WebEx. We have no in-person representation in HQ. Would you like me to close this window?
Yes, thank you. Okay, so it looks like we can move on to the next agenda item. This was a request made by the president of CNMA to update BRN website regarding the passage of SB 667. And there were some links associated with that request. I don't know if there's anyone representing the CNMA on the call, but essentially it appears that SB 667 clarified that CNMs do not need to be in the same practice with a physician in order to consult and collaborate with the physician. It allows nurse midwives to dispense meds within their scope directly to their patients. It allows CNMs to be laboratory directors in facilities that only perform clinical laboratory tests classified as waived or provider-performed microscopy within the scope of nurse midwifery practice, which is of course key to a CNM owned and operated business. It allows for disability certification by midwives for the entirety of pregnancy if the diagnosis or condition warranting that disability is within the CNM scope. It allows the CNM to independently furnish controlled substances if the conditions are within the CNM low risk scope without a standardized procedure. It allows nurse midwives to manage common gynecologic conditions across the lifespan, consistent with the ACNM's core competencies, including during menopause and postmenopause. And it clarifies that hospitals may grant admission and discharge privileges to CNMs consistent with the CNM scope of practice if authorized by the hospital bylaws. And so initially it wasn't exactly clear what the request to update the website was, but I think honestly, Loretta, when I took a look at it after we spoke, it looks like there's just some outdated links on the website that go to like 2012 and 2013 documents. And so I think those are simply a matter of updating the links from the nurse midwifery page to the California Nurse Practice Act, to the nurse practitioner laws and regulations, to the website titled Authorization for RNs to Dispense Drugs and Devices. The scope is described on Advanced Practice of Public Health Nurse Certification page. And the FAQs that this committee worked on that were approved back in 2022, that's going to need some wordsmithing. And so I think that will need to go out to the subcommittee that currently has no member. Is that the website? Or I guess we could do it in the, we could tackle in the scope of practice as well.
Yeah, the website subcommittee is not up and operational at this point, but so on the screen right here, I'm trying to show what you were kind of referencing to, and I'll just back up really quick. So on our web homepage, you're able to come in. This is our homepage. It's rn.ca.gov. You go down here and click on nurse midwife. When you're on this screen, it does have some of the links that you're referencing. And so our Nurse Practice Act, so when 667 was updated, any of the, here, I'll pull this up here really quick. So when you click on SB 667 here, are you guys still seeing my screen here? It shows that section 1209 was updated. That's not part of our Nurse Practice Act. So that will not live on our website. When you scroll down and you see 2746.5, that is part of our Nurse Practice Act. You will see that on our website. And in fact, when you go in here, you click on this and you have 2746.5 right here, right? And so that's potentially why you guys are not finding what you guys are expecting to see. So all of these 2746.5, and then you go down here and you look at 4170, right? And when we pull up our, sorry, let me just add another screen here.
You know,
And
Loretta, these are
yes,
actually not the links that they were referring to, because the links that they gave us go to PDFs, like PDFs from
so
2012.
they will, and I'll cover that as well.
Oh,
So
okay.
the Nurse Practice Act is right here on this page, right? And these are updated every time. This top section here is the Business Professions Code of our Nurse Practice Act, and that is whenever legislation is updated. And anytime legislation is updated, whatever section was affected by that, it is pulled through here. And so Article 2.5 is specific to nurse midwives. And you will see all of the updated language in our Nurse Practice Act. Then, if there are regulations, this is the section of our Nurse Practice Act that belongs to our regulations, and that's Title 16 of the California Code of Regulations. And then we have Article 6 on here, which is specific to nurse midwives. And you can actually tell that qualifications for certification is what's up there. Your committee has been repealed, your abortion by aspiration techniques, your supervising physician, your ratio of nurse midwives to physicians, and your fees have all been repealed. What that means is they're no longer addressed in these sections. So you only have 3 active regulations that are pertinent to nurse midwives. 1460's pertinent regulation is right here, and that just tells what you need to be certified in California as a midwife. The next one is 1463, which is a scope of practice. And so it lets you guys providing necessary supervision. It doesn't specify what that is. And then always understand that statute supersedes regulation in every aspect. So you would refer back to statute saying, what is the necessary supervision? And then statute would explain that. Then it says you can conduct deliveries on the licensed own responsibility in caring for the newborn and the infant, and the care includes preventive measures and the detection of abnormal conditions of mother and child. It says obtaining physician's assistance and consultation when indicated. So again, nothing that is specific. If you needed to go back to the statute is where you would find out when
So I think we're
indicated
kind of
was.
going off on a little bit of a tangent, though, because I think the intent of this request and agenda item was actually just to clean up the website to make it more user friendly. Because what we're hearing, both as committee members and apparently as the CNMA, is that despite the revision of this statutory and regulatory language successively over the last couple of years, that there seems to be barriers to implementation when folks from hospitals or credentialing committees go on the website, Google it, and then get linked to a PDF because they aren't savvy enough to navigate all these different aspects of the language in the manner that you just did. So maybe rather than sort of like debate what is and isn't up there in various places, we could table this and take it under advisement in the, let's see, the subcommittee that had representation on my subcommittee, which was, gosh, I have so many different things opened up right now. It was the scope of practice. And I could simply work with Ruth to navigate the website as though we were a consumer or hospital administrator with no, prior knowledge, and kind of see if we can replicate these issues that have been identified with how to find the correct information. Does that sound like a reasonable plan?
It does, but
Okay.
we also need to provide the education. And so when you're on our website, the thing that we need to have everybody understand is right here in this section that's highlighted right here. And that is where to go when you have practice questions. All of our practice questions are going to be in our Nurse Practice Act right here. And that is where you will click on that and you will find any legislative statutory requirements here in the top. and then California Code of Regulations, which is the essentially policy and procedures that are necessary to carry out the statute. All of your practice has to go back to law. And so that is key. The other thing, and this is recently redone for ease, is just seeing here that you guys have a section called nurse midwife. And so when you come in here blind as a public member saying rn.ca.gov, you've never been to our website before, we want you to go to right here where it's nurse midwife, right? This very first one here that is red, this is our alert. Those are these high alert kind of need to be on the top. But the very next section, which is the most helpful, is right here. And that is on our webpage, and it goes right to nurse midwife. Now, some of the comments that you were talking about, Jenna, this is really where you're going to find them. So FAQs related to midwifery practice is right here on related links. And that is where, if this is the document you're referencing, that is a PDF, it may need to be updated. It was revised in May of 2022. So this would be the document that would need to be updated.
Yeah, I think this is really the only one. And the
That
other
might
ones,
be
I think
it.
we just need to fix some broken links.
Okay. And so then on here, if you're also looking, here are other historical documents, and these might be the ones that you were talking about that are outdated. Those historical documents would continue to live here, but we could add new ones up here. And so there is the, in 2011, there's a midwifery practice under standardized procedures prohibited. And so that is a PDF document that you were probably
Yeah, you know,
referencing
the
that's out
links
of
to the
date.
PDFs are actually in the original email.
Okay.
So they're already, we have them.
Okay. And then the other historical document is from 2003, right here, where it says nurse midwives and nurse practitioners may furnish drugs and devices on their solo practice. So just for everybody to be referenced here, they can see that. And so that is where you would go for midwifery kind of questions. Now in here, the original email, and I do have it, it references, it says at a minimum, the following pages are outdated on the site. And it does reference the California Nurse Practice Act. And so that's why I do want to make sure that you guys understand where the Nurse Practice Act lives in its true and up-to-date form. And so that document that is linked there, we can delete that document. It's just a cut and paste of old text. And so we can definitely delete that. And then the next one that was referenced in there was the nurse practitioner laws and regulations. There is some overlap with nurse practitioner, nurse midwives kind of in there. And we can update that and pull that out and make that separate. And I think that's probably what you guys are asking. The FAQs, that's the document that you just mentioned, Jenna, that would need to be updated. And then there is a advanced practice where you guys go to licensing, that you guys are saying that the description is off. And my assumption is because it's not capturing the newest language. And so we can update that. And then the authorization for RNs to dispense drugs and devices. That is another PDF. And that is talking about dispensing, not furnishing. And so at that point, that is something completely different. But we can look to see if there was anything that was updated in that. But dispensing is different than furnishing. And dispensing is an RN scope of practice as well, and not necessarily limited to advanced practice. And so we can take a look at that if you guys have identified something particular in that document that you think needs to be updated now that 667 has been updated. And I know that Holly has been kind of in public comment and wanting to come in. If she wants to come in now, we can facilitate elevating her by our board moderator. So Mark, if you can elevate Holly Smith so that she can participate in this discussion, I think that'd be wonderful.
Yeah, just while we're waiting for her to join, it looks like that last link does refer to midwives among our RN certificate holders, and it just looks like it's probably outdated because it's from the 2011-2012 session. And again, I think this is just some cleanup because we're hearing feedback that when we try to explain kind of how things have evolved over the last few years, we're having trouble always getting folks to find the proof if left to their own devices because they're just finding some of this old stuff that just needs to get removed.
Yeah, I understand that.
I want to
again, for some further clarification really quick, that document is updated in 2012 and it is from that legislative session. The issue is 2725.1 has not been updated since then. So there would not be new language added to this. And this form would not necessarily be updated unless you are seeing that something directly conflicts from 667 to when this law was written. And if there is a conflicting statement, that would be a legislative change because this is legislation, this is statute, and the board has no ability to change that. It has to go through that process. And I think the discussion around here is education on this particular one because dispensing is not furnishing. Dispensing is handing out that medication. It is not necessarily prescribing that medication, right? And so prescribing is done through the furnishing process, and that is a separate law. There's one for nurse practitioners and one for nurse midwives. This is a dispensing law that is in the normal RN scope of practice that has not been updated since 2012. So my assumption is this would not be out of date. It could be conflicting. If it is conflicting, we would have to do a bill cleanup.
Yeah, I think it probably refers to the line about how a CNM functions pursuant to a standardized procedure or protocol. But I'll let Holly speak to that because she probably knows even better.
Yep.
Hi, yeah, thanks for letting me talk for a second. I really appreciate this is super helpful information. I agree that the FAQ is probably the most important website document, and when we push people to the FAQ, they seem to be able to get what they need to move forward with like credentialing and scope of practice stuff, even if it's not directly mentioned in the regulations, which as it, it is, everything goes back to statute, but it seems like organizations really want to see something in the quote regs as opposed to like, sifting through the actual legislation. So the FAQ document has almost become kind of like a substitute for that and has been super helpful. So I think just the simple updating of the FAQ document will be sufficient. I don't know, this is something for the BRN to think about. If there's anything like to be able to put flashing lights around the click here for FAQ, anything to just elevate, like this is the page you need. But I don't know, that may be beyond the scope of this conversation. So I am happy to hear what Loretta said about some of these things are out of the purview of the BRN, particularly the lab director situation that goes to CDPH. Hospitals may grant admission privileges. That's up to CNMA to discuss with CDPH. And then finally, EDD for the ability to sign off on disability outside of that 36 weeks, as long as it's consistent with scope. That is, however, where we're getting a lot of pushback is EDD is sometimes allowing nurse midwives to sign off on disability for things like nausea and vomiting in the first trimester. And sometimes they're getting rejected for that. And in their opinion, they're saying it's not in the regs yet, or that's what we're hearing. However, CNMA is set up to have direct conversations with EDD in the near future. But this is where my question is the FAQ document a place where such information can be placed so that EDD can see that, and then there's kind of like a crossover between agencies, or they can be like, oh, okay, BRN has this on the website. In fact, that is the case since the BRN is, our administrative body for scope. Is that something that can be put in that FAQ?
That is a location where it can live. One of the other suggestions, and I'm going to screen share again, so that you consider that when you guys are looking at it, is looking at this part of our web page. Let me see if it's going to share here really quick, where it is specific to nurse midwife practice. And so what you might want to do on the other resources, where it is a link to the CNMA, where it's a link to the American College of Nurse Midwives, etc., is we may want to add a section on here that says for insurance information, go here, and then click a link to CMS. For facility information, go here, and then insert a link to CDPH.
Gotcha.
You could also, suggest for EDD disability information, go here, and then a link directly to EDD. So we could add on the other resources, which are outside links, those other governmental agencies. And that's the key, is they need to be, governmental agencies if we're going to be directing them in that way.
Okay.
And then, yes, on this FAQs related to midwifery practice, you could call that out. Right here, it talks about the implementation of 1237. So what we could do and highlight on this is say this is FAQs related to midwifery practice, subsequent to SB 1237. And we can do a separate FAQs that says related to midwifery practice subsequent to the passage of SB 667. And put the dates on that. And so if you're looking for something specific in that, we could update those areas, unless you think it would be best to kind of mix this and put in the implementation of SB 1237 with this section and this one. If you don't think it's going to be too extensive of a document, we could combine them in this document so that it's there. Because I know that 667 was kind of a cleanup of 1237.
Yeah, that almost
And
makes
so
most sense
we
to
could
me.
put that in there. It's not like it's a big reach to say it was a lot of additional things. So we could just update this. But again, that comes from the feedback from you guys on what you think would be more beneficial and easier for you guys to navigate through.
Gotcha. So we should direct that feedback perhaps to one of the subcommittee people to bring to committee. Is that?
Yeah, so what it looks like to me is that just in this discussion and kind of knowing how this works is I don't believe 667 requires any regulatory work. I think it was all clarified in statute, and we do not do duplicative regulatory work, right? If it's in statute, we refer back to statute always because statute supersedes regs. So we would just have to kind of say on this FAQs where you guys show like, it says, can CNMs care for patients? And let me share again so that everybody in the public has it up as well. Can CNMs care for patients that fall outside of the defined low risk scope? And you can see that it references back to the statutory language in 2746.5 and subdivision B specifically. And so we could go through and do that on here. So again, I don't think it's a regulatory ask. I do think that it is, going to this FAQs, making it as usable as possible and referencing back to the specific codes, because that's where EDD, CMS, CDPH, they're all going to go back and look, because that's where your scope of practice and your ability comes from, is that statutory language.
Mm-hmm.
Now, the next ask on this is whether or not after we update the FAQs, what do you think would be a benefit? And those were those two additional documents that were referenced that were just a cut and paste of old regulatory language and old statutory language. That's a process that we've moved from. And so anytime we come across those documents like you have, they need to just be noticed to us, and we're going to pull them down because
Yeah.
that's absolutely unnecessary to have duplicative language that we're not updating because the statutory links and regulatory links are what needs to be updated. And so hopefully we can get those off.
Perfect.
And then you think that, and then it looks like on the advanced practice, which is actually on that same webpage, it's the same descriptor, needs to be updated. And what language are you seeing that specifically needs to capture? And that is that the STDs, STIs kind of language that needs to be added, or was there something more?
The only thing that I can see that potentially needs a regulatory change is care for common gynecologic conditions outside of pregnancy, because that is different than what's in regulations right now for scope, which just includes, within pregnancy conditions and in interconception care. But I think because care for common gynecologic conditions across the lifespan is such a specific practice, that it should be clarified that that is in fact the case now for nurse midwives outside of even the pregnancy state. That's the only thing I can see that would need a regulatory, or in my opinion, but I think that's up to the committee and council who's here to figure out if that is in fact the case. But that seems to be so much of a new thing that it should probably be put in A there, providing necessary supervision, care, blah blah blah, and it names all those periods, and then comma, and care for common gynecologic conditions across the lifespan could be an
Okay.
easy fix.
So that you could see that A would just need to have that additional language added so that we can
That's
align with the statutory language.
Yes.
Well, that's
Yeah,
a
that's the only
that's a
thing I
quick
can see.
fix.
Yeah.
Okay. I mean, and I say quick fix as it's still a regulatory process and can take a year or two.
Right.
And so in the meantime, we'll still have to update the FAQs. But that to me seems like something that can that could work. And so at this one here, it looks like James and Lilith, she just did the work for you. So you don't have to work on that for regulations. It's just adding that one a comma and that, and
Thank you.
it looks like that's sold. No.
Yeah.
So just to kind of share that out with you guys, that does look like a simpler fix. If you guys don't have a lot of pushback on that, I think we can move forward with that. And then we will, when the language is drafted, we'll bring it back to this committee. So we're looking at the March committee potentially to have that language added. If you guys agree, then we'll move it to committee, board committee, and then board, and we should be able to get that moved through quickly. If we're able to do it in what's called a Form 100, where it supports the statute without any kind of substantive change at all, and it should have no effect, essentially. We potentially could get that done sooner, but I can't guarantee that that would happen. Office of Administrative Law is very strict on what meets a Form 100 guideline, and we'll just pursue with our regulatory, DCA regulatory attorney, as well as my chief of legislation, Marissa Clark, and we'll see what next steps are to answer this. But you guys, please work on the FAQs. And then we'll bring those back in front of the committee as well in May, so that those can be updated. And if you, there is no website. So Jenna and Ruth, if you guys do see something that you think would be nice to add to the website to clarify scope of practice, give me those links and we'll try to get those added to our website on that nurse midwife page, so that we can help facilitate with that with you guys.
I have a question about that, because I really like Jenna's idea about making sure. So I think one of the issues that hopefully is coming up more and more is hospital medical staffs are thinking, especially now that all these hospitals are closing and we're really focusing maybe on enhancing providers at the ones that are still open. Can we add nurse midwives here with independent practice? I think that is a key issue. So I would love, like Jenna said, to go through and, be that person kind of try to find that. And my question is, could somebody join us in that, like from CNMA, that, you know, another set of eyes, or is that something that Jen and I need to do?
In your subcommittees, you guys are able, and even in your advisory committees, this as a whole, you guys are able to talk to any subject matter expert that you want, except for additional people on this committee. So who you couldn't speak to, Ruth, you and Jenna could meet, but you can't have a conversation with Lilith. You
Yeah,
can't
right.
have a conversation
Okay.
with Dr. James or Dr. Byrne, right? So that's what you guys have to do is Ruth, you and Jenna, if you guys want to meet with anybody else that is not on this subcommittee or on this advisory committee, sorry, you can. 100%. We have no exclusionary language in any way.
And I'm sounding really paranoid. Do we have to notify you who we're meeting with?
No, you do
Okay.
not. You can meet with whoever you want. And then,
Mhm.
like we had in the previous meeting agenda item, where you guys do a report out at that point. So if you guys actively go out and start working as you and Jen as your subcommittee over the next few months before March, in March, when it says report out, you and Jenna would come in and say, this is what we did over the last few months. We've met with this person, this person, this person, or these groups. And if you didn't want to do persons, we met with these groups. This is the information that we received. This is the product that we have here. We will discuss that in the next agenda item for you guys to accept the updated FAQs, you know, et cetera, et cetera.
Okay. Thank you.
Jenna, if you're speaking, you're muted.
Yes, I was. I was just gonna say, this sounds like an information only, and that we don't need to make a motion to move forward in the ways we've discussed with this information. So we can turn it over to public comment if there's any further comment.
Perfect. We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, I would like to make a comment. Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. And Holly Smith, I do not have a comment. No need to unmute. Just want to let everyone know this has been very super helpful. And Committee Chair Shaw Batista, there are no public requests for comments on the WebEx. We have no in-person representation here in HQ. Would you like me to close this window?
Yes, thank you.
Okay, and then real quick, so this is information only, we would not need a vote. Board moderator, can you elevate Marissa Clark, Stephen Vaughn, and Shannon Johnson as potential people that could provide input as we move into the next agenda item 9.0?
So I don't know who wants to present this. Is this something that you wanted to run through, Loretta?
Yeah, you would just open it up and say that we're moving on to agenda item 9.0.
All right.
Explain what it
Agenda
is, and
item
then I'll take over.
9.0, regarding input from NMAC on changes to the BRN disciplinary guidelines to provide recommendations or guidance on care when the board is considering disciplinary action against a CNM.
So we previously had brought disciplinary language forward to your advisory committee as well as the nurse practitioner advisory committee. And we were looking at language for the independent practitioner because we had not had language for that previously. And we want to allow for our advanced practice RNs to continue to do their independent practice while they're on probation. Our current disciplinary guidelines don't allow for that, and they require supervision at least, once or twice a shift, or which is minimal, and then moderate is half a shift, and maximum is the entire shift that you work. And just in that language, talking about shift, that doesn't really address the advanced practice RN, right? And so we had brought forth language that mirrored very similar to that minimum, moderate, maximum language. However, as we progressed through the process and reviewed more resources, looked at disciplinary guideline language that has recently been passed or updated through OAL, when in Office of Administrative Laws, OAL. So as we started looking at that, we looked at the language that we had proposed and that you guys had accepted with some edits, and Nurse Practitioner Advisory Committee had accepted with some edits as well, that we would have to be much more explicit in our language that would say, you must do this, 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 and this. And it became very prescriptive in order for it to get through OAL. And so we looked at recently passed disciplinary guidelines from other healing art boards, and we decided to scrap that and follow suit with what other boards have done. And so in front of you, starting on page 27, in the bold, is the new proposed language. When you look at the top of the page on 27, where it's supervision and it is not in bold, we are not addressing that. That is our current disciplinary guideline language for our traditional RN, our non-independent practice RNs, right? So if that is our current language, if we were to bold it, that would be new. If we were to underline it, that would be new. If we were to line through it, that would be removing it. So scroll down to E, and where it shows E, you will see the bold language under E. That bold language is the added language that we would like you guys to review and consider. And if you do, we would ask for a motion where you would accept this language, and then we would ask for that language to be moved forward to our board for consideration. And this would be the path forward for our disciplinary guidelines for the independent practitioner. And the independent practitioner makes everybody aware, this is for nurse midwives, nurse anesthetists, and nurse practitioners. So it is a very broad section that allows for all three of those. Additionally, if the clinical nurse specialist were to obtain independent practice here, as they do in other states, it would encompass their role too. So there cannot be over specificity by role. It is just a general supervision guideline. This is common language used by dental board, medical board, osteopathic board, physician assistants board, etc. So see if that's something. And then I'm going to hush and let Marissa and Stephen and Shannon answer any questions that you guys might have.
This is Ruth. Is there some type of prescribed format for deciding if the plan of supervision, I mean, who's doing that? Who's reviewing the plan? How often do they meet? Is there some kind of template? Maybe this has been done already.
It is. So Shannon and I can kind of bounce off each other on this one, kind of to go over the process. So currently, when a ruling is brought forward, it will give some specific guidance from a legal perspective on what is required. When we get that information, we have a nursing education consultant that works in enforcement and that person gets all of the job approvals, course approvals, and modifications put in front of them for review. And so the current practice addresses, and I'm going to screen share here for you guys, again, the meeting materials, addresses the section on supervision. Sorry, here, I'm going to change that screen. There we go. Addresses the section on supervision. That is 8, which is the non-bolded language. And so to kind of talk about that process is it, say you have an RN that had a scope of practice issue, say they hung blood on the wrong patient and falsified the documentation and didn't let anybody know that that happened until the next day, the morning H&H was drawn and the patient that needed blood continued to be low, and for some reason another patient had a higher H&H, and they tried to get to the bottom of that. So there would be that person would be placed on probation, have some courses assigned to them by the NEC to address the knowledge deficit, and then they would say, okay, taking into consideration everything, this person, we could do, moderate, moderate supervision. And I'm just throwing this out. This is not accurate in any way. Moderate supervision says that if they work a 12-hour shift, they need 6 hours with a nurse that is equal to or above them to work with them. We could also look and put in whether or not they can have narcotic access or not. This is a practice issue, so would not necessarily look at narcotics as being an issue. And then you would look, okay, can they work on night shift? Can they work on day shift? We would look at what kind of their onboarding practices are. Do they need some orientation with the coursework that we're giving them? Do we think that that's an okay process? And then do we think that any kind of worksite monitor reports, how many, how often, every month, every 3 months, and then also look at whether or not we would like them to do any chart reviews. So do you want to pull a chart of that RN? Do you want to review 20% of their charts? Do you want to do 2 a week? What do you want to do to ensure that no further errors like that occur? And so that is the common practice now. But that is not something that facilitates independent practice for our advanced practice RNs. And so what would happen at this point is the language that's here, and it says that the nurse midwife or nurse practitioner or nurse anesthetist works collaboratively with this. And so I'm going to have Marissa or Shannon jump in and talk about how this plan could be implemented.
Sorry, I was in the middle of reading that. So with the new plan, I mean, it would still go through the nurse within the enforcement unit. Normally what they do is they will, and I see this kind of being true for the midwives, any advanced practice, they would need to review the disciplinary order. They would then obtain a CV or resume from the nurse, determine, if the job they're providing. So if they're providing employment that they want to have approved, we would ask for an org chart. We would ask for a duty statement of what the jobs are or the job tasks are. The nurse on staff at the board will then review those documents. They will contact the employer. They'll have a discussion on what's appropriate. They will determine what level supervision is necessary or needed, and that will be discussed with the employer. They will discuss reporting and what type of reporting may be required for this particular person. And remember, each one is on a case by case. There's no blanket across all of them. So depending on what the violation was that put them on probation, the level, they take everything in totality. when they're looking at that. So there's never going to be two cases that are exactly the same. So we do have to look at everything in totality to make that determination on what would be appropriate for this specific person in this specific situation. And then all of that would be discussed. There's, we can either ask for monthly employee evaluations from the employer. Sometimes it's quarterly. Again, that just depends on what, where this particular case is. And again, you saw with the numbers, we have very few nurse midwives. So you're probably looking at 2 in a year that we get, maybe max. So that's all reviewed by the nurse. At no time is it just a analyst within our staff. It is always going to be the nurse that is on staff that will be reviewing all of the employment, making those determinations, speaking with the employer, and determining if any continuing education is needed.
On that, does that nurse have access to a respective consultant for the APRN being representative? I mean, when you're talking about a 12-hour shift, that may not fit for, if you're on call for 24 hours, what does that mean? So I think it'd be really nice if they had access to a consultant as they made that determination.
Correct. And so the language that I talked about, shift work, that is for your RN. That is the part of the disciplinary guidelines on page 27 that has not been altered and would not be utilized for this. That 12-hour shift, those 6-hour shifts, 8-hour shifts, whatever it is for the traditional RN. The new language starts in E, and that new language that starts in E is for the advanced practice RN that works in an independent setting that does not utilize standardized procedures. And so what that language talks about is that after you guys go through the legal process and you guys get the decision in order, which comes from the court systems, not us, that decision in order tells the respondent or the nurse midwife what the practice restrictions and the practice guidelines are. And then that decision in order is what is presented to the nursing education consultant to review, to have on the file until you guys, the nurse midwife, that is the respondent, brings forward a plan that says, this is who will supervise me and review my charts and work with me while I continue my practice. And so that is where that kind of review takes place. And so your nurse midwife is the one that says, I found somebody that can oversee me. This person is equal to or above my scope of practice. That person will be providing the supervision that is ordered, whether it be direct and require the physical presence of a supervising provider in the office during the time the direct patient care is provided. That includes whether or not they do call hours at a hospital, or it is not required to have the physical presence during the time direct patient care is provided, but you only have to do an occasional random check. And that is going to be ordered by the court systems in the decision and order. And you guys would find the person that would help you guys do that. And you guys, as the nurse midwife that has the issue, that brought them forward to our enforcement and probation area. Then that person that is supervising says they shall have full and random access to all patient records of the respondent, and the supervisor may evaluate all aspects of the respondent's practice, regardless of the respondent's areas of deficiencies. And then it says each proposed supervisor shall submit written reports to the board on a regular basis. That would be determined whether it be monthly, weekly, every 3 months, every 6 months. And then it shall be the respondent's responsibility to ensure that the required reports are filed in a timely manner. And then it does state that each supervisor shall be licensed in California for at least 5 years and shall be trained in the same specialty or content area as the respondent. And then it puts the limitations on there, which it says you shall not have prior current business or close personal or familial relationship with the respondent, and that the supervisor shall not have been subject to any prior disciplinary action by their licensing board. And then it does say, again, a clarification that an administrative citation and fine does not constitute discipline, and therefore in and of itself is not a reason to deny an individual as a supervisor. So this is the section that allows you to do those call shifts. This is the section that allows you guys to have an office practice and not a shift-based practice. And this section is the one that allows you guys to bring in a nurse midwife or a physician that is equal to or higher than your scope, that would be the supervisor of you all while you're on probation. So hopefully that provided that clarification. So do not look at A, B, C, and D. Those are not being modified, and those are for the traditional RN. E is the one that we're asking you guys to look at today, and that would be a process that is set up through the nurse midwife that is on probation and the nursing education consultant here assigned to our board, their probation monitor, and it would follow the guidance that is issued them in the decision and order that is done through the court system.
I have a question. I think you clarified that it's an independent practitioner, not the setting. So you can be an independent practitioner no matter where you are. So let's take that example and say I'm a nurse midwife who managed to get myself admitting privileges for a low risk scope. I have no supervising physician. I don't do anything beyond my scope, but I work in this hospital and I get some claim and I have to come up with a supervisor. How, if I can't have a business or personal relationship, that would imply that like the folks that I work with at the hospital are out. Certainly if they were in my same practice, or no? That's not that doesn't constitute a business relationship? Because I guess my bottom line question is, where did these timelines come from, and are they realistic if we had to get somebody credentialed in the hospital to supervise us? No, we
So
couldn't do
what
that.
you would look at is like your hospital setting, right?
Mhm.
Is there a chief of staff, a chief of medical staff, or something like that? You do not have a direct business relationship with them. They're not signing your check. They're not paying for you. They don't have the private practice with you. And so you could look to see if there is somebody there that would allow for supervision while you're there. You can have multiple supervisors. It's not just a singular one. So if you are at hospital A, you could have a supervisor that would fill in there. It could be another nurse midwife that is not in your practice setting, but has their own practice setting. And at the hospital, they can work collaborative with you and work as the supervisor there. So you would find a person, a midwife or a physician who would be willing to supervise you in any of your practice settings. And then you would present that as part of your plan that says, when I am at hospital A, this would be my supervisor. When I'm at hospital B, this would be my supervisor. When I'm at hospital C, this would be my supervisor. And when I'm in clinic, this would be my supervisor. And if it is one that suits all of them, fantastic, especially if that says that your decision order says you don't require physical presence. It could be one, and they could look at all of your records during that time. And if it is not one and it requires a physical presence, you might need to have multiple nurse midwives or physicians that would oversee you in various locations. And so if you were at hospital B and you were the only midwife, you may need to have a OBGYN that would supervise you or serve as that person. You may need to look at the call schedule of who you're on call with most often, and then your schedule would have to follow the call schedule of the supervisor if it was required that the supervisor is physical presence with you at all time. And again, that's a legal requirement, not a BRN requirement. That would come from the decision appeal. The courts would issue that, and they would say what that type of supervision would be based on the incident that brought that midwife into this probationary aspect. Because what that is determined is if they're on probation because they've been determined to be unsafe at this point. And so that supervision is what's required to ensure that there is safe practice continuing. Or, you know, if this pathway is not there, then that independent practice can't continue, right? And so that's why we need to have this independent section added to our disciplinary guidelines to facilitate that.
No, I get
And
that, and I'm glad. I think we had talked about it in the last meeting. I'm just trying to think of like logistically, how would this actually work, especially in the scenario of you work multiple places and you want the same supervisor because they don't have to be present. Well, how would they even obtain access to patient records at 3 different facilities? So,
that's
and if they were going to do that, how would it happen within 60 days? And so I guess maybe one question is, would that midwife just need to have a plan within 60 days, or does it have to be a plan that's been implemented? And the
if you're to go
backstory there
back
is
to
that if it's
work,
not implemented, they don't have any income. So they
in
can't
order
be
to
your
go back to
supervisor.
work, yeah, in order to go back to work, the plan has to be implemented. You
Got it.
cannot go back with a proposed plan. That plan has to be approved. Now, it may be those records. So once you have an admission at a hospital, right? When you follow them in your primary practice, outside of that, those hospital records are shared with you. And they're part of your chart in your clinic setting. And so they can review those hospital records that are provided in that clinic setting that you have access to via your clinic EMR.
If
right?
they are credentialed in your clinic.
If they, well, no, they don't have to be credentialed in your clinic. They are a supervisor in your clinic. They are supervising you in your clinic. You would have to manage how that would be, and it doesn't necessarily mean credentialing them. It could be a contract like setup that you guys get approved that during this time while you're on probation, they have access for this. They're not going to be credentialed because they're not providing care in that clinic. They're not doing hands-on care to any of your patients that you're seeing. They are there supervising you. They are not there to take care of your patients. So that is a separate process. And so Dr. Byrne or Dr. James, are you guys able to share how this happens in the physician setting? That is a much more familiar area on how these practitioners as a physician surgeon are independent and how you guys manage through this process to provide some additional clarification.
Well, luckily, I haven't had to experience this, but I will tell you, I was a solo practitioner for 15 years, and I did have several midwives working under me. And I tell you, if this happened to me, it would be tough. It was hard enough for me to find a call coverage for somebody who wanted to cover my practice with the midwives. But, you know, the problem is when you're a solo practitioner or an independent practitioner, unfortunately, those are the risks you have to take. That if there is disciplinary practice or if there's action taken against you, you're kind of screwed, and you're going to have to be willing to lose income. You're going to have to be willing to ask for favors, and you're going to hopefully you build good relationships with people at your hospital who are willing to cover you. I mean, most hospitals nowadays have a laborist program, so I'm sure the laborist would be more than happy to supervise your work in the hospital. You know, hopefully you have a friend who's a midwife that's willing to come to clinic, and maybe your clinic hours will have to change from 5 days a week to 1 day a week just to get the supervision. It's hard. That's why I don't practice by myself anymore, because being a solo is difficult. So that's the best I can tell you. I mean, I think this, the changes are excellent. I think if you have disciplinary actions, that really is a bummer, but that's part of practicing medicine. We make mistakes, and then we have to, recover from our mistakes. I mean, it's like when I joined a new hospital recently, I had to get my privileges approved for surgical cases that I've done 1,000 times, but I had to get proctored for each case. Let's say 10 hysterectomies have to be proctored at a new hospital, even though I've done 1,000 of them. That's part of the processing. So if there's discipline, you got to, and I had to find people to help me with surgery, which is harder than you think. So I'm not sure if that, I hope that it helps explain things. Listen, if you have a group practice, it's easier to get people to monitor you. If you're by yourself, that's, you check your ego at the door and you find somebody to help. That's the hardest part is finding somebody. That's all I got, and I approve the changes.
Thank you. So it looks like we do have a motion to approve by Dr. James. Is there somebody that would like to second?
I second to approve the changes.
Thank you, Lilith. We can go out to public comment now, Ruth, if you want to, sorry, Jenna, if you want to bring us out.
I'm going to give Ruth just a second. It looked like she was maybe going to say something. No. Any public members have a comment on this topic?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Shaw Batista, there are no public requests for comments on the WebEx. We have no in-person representation here at HQ. Would you like me to close this window?
Yes, thank you. Okay, so there has been a motion to approve the changes as proposed, which was seconded. We will go to a vote, correct? So let's see. Lilith,
Yes.
Ruth,
Aye.
okay, and Kenneth. I think I'm going to abstain if that's a possibility, just because I feel like I don't quite understand it. But I believe it's, or no, because we're only 4 and we need 4.
It is majority right now that would pass. I'm looking to see our reg council. Stephen, did you have any, would there be any issue if this went to OAL where it showed a person that would abstain versus taking a vote of yes or no? Or would that be more around our board members and less around an advisory committee?
Right, that would be just the board meeting.
Right.
So then Jenna, yeah, you can abstain.
Okay. So with 3 ayes, we have approved the proposal as it reads. Amazing. I'm being very efficient today.
That is the end of the meeting. So at this point, there are no further agenda items. Jenna, if you want to adjourn us, you have successfully made it through your very first meeting. And we
I'll
have
deliriously tired, no less.
It'll make
Maybe I should come to more
the
meetings
sleep all the
post-pub.
sweeter. Yeah.
Yes, definitely. Wonderful.
Well, I
Thank you
move to
guys.
adjourn. Thank you all.
Wonderful. We are adjourned, 10:52.
Good job,
Thank
everyone.
you.
Bye.
Bye-bye.
Thank you.